back and forth, but I want to be right next to the, or do I want to check out the, but
Hi, everyone, just going to give folks a few more minutes to log on. Thanks for being here.
Oh, it's so good to see you.
All right, everyone. Good to see everyone. We're going to go ahead and get started. Great to see everybody on the call. Welcome to our Wall Family Speaker Series on health, spirituality, and religion. Today, we are really excited to be welcoming Dr. Aasim Padela, who's joining us from the Medical College of Wisconsin. Before I introduce Dr. Padela in our session today, I just have a few announcements. If you are a medical student and you are interested in joining our humanism rounds that we're having tonight, our Fearless Fellows are running humanism rounds, round 2 tonight. It's at 7 p.m. We have reserved Taubman 6380. And the topic, again, will just be with medical students discussing two concepts in medicine. What does it mean to experience awe? And what does it mean to experience wonder in medicine? And how do these ideas of experiencing awe and wonder maybe contradict with traditional notions of professionalism? And what are the threats to experiencing awe and wonder in medicine? So join us if you're able to. You can reach out to me or the fellows if interested. Also, for any students, any level of students in the group, the student essay contest for the Conference on Medicine and Religion is open. The theme of the conference this year is In Pursuit of the Great Coherence, Healing in the Spaces Between. And if you write an essay and it's accepted, you have funding to attend the Conference on Medicine and Religion, which is a wonderful conference. It's going to be in Indianapolis this year. Aasim and I have been several years in a row. It's great. Maybe a third to half of this conference at times are actually students from across the country. So reach out to me if you need help with submissions. And as always, Dr. Adam Baruch, myself, and the team remain available to any member of our community to discuss any issues you have on your mind. Dr. Baruch and I have been having office hours, as many of you know, and we've been really thrilled with the engagement from so many members across our community. But we are totally available to meet one-on-one also, but we'll continue to have office hours. And now for our session. So we are really thrilled to be hosting Dr. Aasim Padela from the Medical College of Wisconsin. So I will be introducing him here, and then he will make his formal remarks, and then we will transition to Q&A. We are helped today by pre-medical student Amar Khan, who's on the call. Thanks, Amar, for being here. He is part of the Michigan Muslim Pre-Meds Association here at U of M. And he will be Amar will be running our Q&A. And now I have the pleasure of introducing Dr. Padela. Dr. Padela is a professor with tenure of emergency medicine, bioethics, and the medical humanities at the Medical College of Wisconsin. In addition to being vice chair for research and scholarship in the Department of Emergency Medicine, he co-leads the Community Engagement Core for the Comprehensive Injury Center. He serves on the Council of Faith for the Clinical and Translational Science Institute at MCW and holds a faculty appointment in the Center for Bioethics and Medical Humanities in the Institute for Health and Equity. He received his MD from Cornell and a master's in healthcare research from U of M, go blue. He also holds a BS in biomedical engineering. And from what I heard recently when we were at dinner in Ottawa, Canada, he wanted to do space medicine at one point. And he has a BA in classic Arabic from the University of Rochester. He completed his residency in EM at the University of Rochester and a clinical medical ethics fellowship at McLean Center for Clinical Medical Ethics in University of Chicago. Additionally, his training includes visiting fellowships at the Oxford Center for Islamic Studies and the International Institute for Islamic Thought. And his scholarship is really unique. It aims at improving health and healthcare equity by better accommodating religious values in healthcare delivery. His current projects span behaviors related to cancer screening, organ donation, end-of-life care, and the like. He holds many positions on many boards, and his peer-reviewed work has been in 120 different articles and books in different formats. And his work has been featured in all the places: USA Today, Chicago Tribune, Washington Post, CNN. So with all of that, we are really thrilled to have Dr. Aasim Padela here to join us today. Aasim, thanks for being here. The floor is yours, my friend.
Thank you so much. It's a pleasure to be here. It's a pleasure to see this program grow and sort of have greater impact. So it's really, really good to be with you. Apologize I can't be in person with you all today. Hopefully there'll be some engagement in our conversation today that will help us to feel like we're together. So let me share my screen and get going. And the other thing I want to apologize, my Zoom didn't update, so I don't know if they'll be a little choppy. It seems it might be, so I apologize. And if there's some question, please just put it in the chat, and Amar will be tapped to bring it up, or I can rewind a bit for you if you need to. So can we see the screen? Just thumbs up from someone. Do you see my sharing? Yeah. All right. So this is not the right talk. So let me stop that. 1 second. Sorry, web version is giving me an issue. Today I was asked to speak a little bit about 2 different talks, and I'm going to kind of try to merge them together and have some conversation. I'll speak about the moral maladies of medicine, and I'm going to give you a sense of that from an empirical background, but as well as a commentator, as an observer, as a participant in our healthcare delivery system. So to begin with, you've heard my background. I want to share with you a little bit of where I'm presently at. Some of you know me for a long time, but my work has to do this intersection between Islam, bioethics, and the healthcare system. And I look at work, do research from a theological lens, as well as from an empirical and a bioethical lens. The goal of that is to understand how religion animates the healthcare behaviors and the healthcare challenges that occur for Muslim patients, thinking about how Muslim physicians use their identity as religious beings and how that might pose some challenges, particularly bioethical ones, in the healthcare system. And then also think about how religious scholars, right, those who are within the United States as well as abroad, use the tradition of Islam, excuse me, to engage with modern medicine, right? How they provide guidance to policymakers abroad, but also to clinicians and patients here in the United States. That all sets up work that is interventional in nature, both within healthcare academic settings, that might be policies of how to better accommodate patients and the religious dimensions of their care, or it might be around communities where we have educational interventions to help Muslims and Muslim patients engage with the healthcare system more faithfully. That can lead to some work that's educational. It can lead to some work that's dialogical, and then also, as I mentioned, some sort of ethical commentaries, policy work. I want to bring some of those things in today, but I'm not going to bring all of them in today. And hopefully in the conversation, if you want me to talk about something from these other lenses, I can as well. So the maladies that I want to speak out today are 3. The philosophical malady that I believe is a reductionism and a wholly naturalistic account of human beings. A operational malady in the healthcare system, which is commodification and corporatization of healthcare delivery. And then a cultural malady, which is inhospitability, and the establishment and entrenchment within the healthcare system. All of these, I think, feed on one another. And within my experience as a physician, as well as the research work that I do, I've seen this in many different dimensions. So I'm going to share a few with you. So let's start with the notion of reductionism. right? Well, I think that we can say, or we can see this when I ask you, and since I'm on the web version and not on the Zoom version, I'm not going to be able to see the chat, so you might as well just unmute yourselves. But you can see this in the way that we think about doctors and their role in dealing with diseases. So I'm going to ask the group here, right, and someone can unmute, what do you think is the essential relationship between a doctor and a disease? And please unmute. I can't see the chat in the way I'm looking at this.
Doctor is there to cure the disease.
To cure disease. Okay. Another metaphor someone might have?
Enemy.
Sorry?
Enemy.
The enemy. So doctors are the enemy of disease. Right. So oftentimes when I do this in person, we get the first one, right? Cure, heal, ameliorate. And the second one, right? Combat, fight, terminate. There's two different metaphors, right? One is as a modality or metaphor of war. The other might be of sort of, attending to or addressing. But what I'm going to posit for a moment in the way that we can see reductionism is in the way that we define disease. The doctors actually have a huge role in defining what disease is. And I'm going to this is rhetorical, but we do define disease. Let me help you think about that in a certain way. Does a child who is born deaf have a disease? And if you were to ask doctors and do a national survey, do you think they would say this person has a disease? And the same thing, does a person who is not able to conceive a child have a disease? If you were to ask a group of physicians around the world, do you think they would say yes or no? Or someone who is unknown for an unknown reason has short stature, do they have a disease? And if you were to get the body of physicians across the world, I would argue that they would say all of these individuals have diseases. And that our medical practice helps define and then address those diseases that are defined from a biomedical lens. But if you were to ask people outside of the medical profession, they may or may not agree with that notion. So in defining disease, there are many ways one can do this, but I'm going to give you several terms in the way to think about, again, how our reductionism is operating. So here are some related terms and ideas. A disease could be just dis-ease. And that would be defined by the subject who's going through the being ill at ease. Right? Or a disease could be related to disability. And that means where someone has less ability than what is considered to be normed by that individual or by society. A disease could be a disorder. And here, this could be defined by professionals, right? So this is how things should be psychologically. This is how you should act, right? Or it could be defined by individuals that this is how the biological substrate that you're composed of should work together, right? Or how it look like. And then dysfunction, how it should look together, how it should work together, right? And that's also defined by professional society. So disease is not a simple thing, although as we go into medical school, we think it is. But it can be related to all of these terms and defined variably by different stakeholders in the game, right? The subject themselves, society that we live within, right? Or our own profession. So my truth claim here is that all of these, right, involve a truth claim that an individual has an abnormality or an impairment or a deviation, and many different terms you can use there, from some positive norm that or some positive standard of physiology or social behavior. And physicians, and those of you who are medical students, are part and parcel of defining that and then attending to that. But the way that we look at this is, in a sense, reductionistic. So moving forward, the myth is, from where I stand, that these terms, disease, disability, dysfunction, they're self-explanatory and they're contentful. But I believe they're not contentful, right? If these are vessels and containers for meanings that come from outside. Diseases become grounded in social and bodily realities. And then doctoring, attending to or addressing those diseases becomes embedded within that reality, right? You're attending to those realities that are externally defined. Healthcare, then, the delivery of healthcare, must be instantiated and socially structured in response to a shared or negotiated terrain. And oftentimes, we don't take the time to negotiate that terrain or to share conceptions so that patients and doctors or communities and healthcare systems have a singular expectation, or at least some expectations from the healthcare system of what is disease and how it will be treated. We often neglect that. And in medical training, again, sometimes we just gloss over these ideas. So what does that lead to? That leads to various caricatures of what medicine should be about or what the profession of medicine should look like. Early on, you have here, right, from the 1960s, the notion that physicians are men against death. Prior to this book, the first book was Microbe Hunters, right? That we're looking for disease, that we're looking for agents that cause disease, and we're going to combat them. Or death is the enemy, and we're going to be men, right, against death. Later on, you had this notion, okay, we have corporatization of medical care. Perhaps medical care should tend to what people think are the maladies that they face, a subjective notion of dis-ease, right, being ill at ease. And then we have stories of individuals who potentially think that medical care should tend to how they think about what they should have. In this book by Carl Elliott, Better Than Well, there's some interesting stories around different ideas of that. And then people in the ethical profession or bioethicists have said, no, perhaps there should be a shared notion. We should reclaim Hippocratic ideals about what medicine is about. And perhaps, and even in a plural society, we can come together and say, this is what the core, the goods are of medicine that we deliver as the professionals. It's all negotiated and oftentimes not actually done. Negotiation is not done very well. I think the cause of all of this is that in medicine we don't have a single notion of what the human being is, or we have lost that, and we have to recover the notion of the human being. In the way that we teach, in the way that we practice, we often deal with only the material and formal causes of what the human being is. We don't think about or address the efficient or the final causes. And this is not something I've come up with. This is many scholars have talked about this. But that's where medicine has gone. Again, this is a reductionism, right? That we think about certain causes but not others. And the way then we attend to diseases that we define, the diseases are defined material and formal causes. And then the response, the treatments are also in those sort of domains. The others we rarely attend to. And if we attend to them, we attend to them on the margins of what is the dominant healthcare delivery model in the United States or in other globalized, industrialized nations. This is seen in this sort of model, right? That we think about the biopsychosocial, the biopsychosocial spiritual model of healthcare, and we think mostly, dominantly about the biological dimension of human beings, right? Sometimes we think about the psychological dimension of human beings. We have to get people out of the hospital, think about the social dimension of human beings, but we don't fully attend to those. And the recesses are the spiritual dimension of the human beings. Yes, you might have chaplains. Yes, you might have spiritual care support mechanisms, but they're not the dominant way in which we, as medical professionals, attend to beings, right? We consult others and leave it out. Although there are some programs that try to make it this part and parcel of doctoring. So I'm going to say that religion is a determinant of health that we know about, right? Even our healthcare service just shows this, but again, we ignore it oftentimes, right? That it's embedded within other things that are more dominant, more important, perhaps. So although there is a health status link to spirituality, it is not something that is at the foreground of educating individuals about it, right, who are going to join the profession. Although there is a notion of communal health that arises from participation in religious activities, again, it's sort of on the side and the margins, or even in the way that we deliver healthcare. We know institutions, many institutions in the United States, right, Catholic institutions, the ones I'm thinking about, they deliver healthcare from a certain religious lens, right? But we often don't think about how that animates the whole healthcare system. Only in terms of conflict, right? When there's an ideology conflict, we say, okay, well, look, that's where religion's at, right? And they're the ones that we have to address, and we have to kind of marginalize that so that we don't have health inequities. I would argue we have health inequities partially because we don't attend to the religious dimensions of health. And I say that from decades of work I've been doing on Muslim American health disparities. So let's take an entity, moving to kind of a little bit to the second part of my talk, or the second malady of reductionism in action. Right? And I think a great way, and I've done a lot of work on this specific entity, is in the notion of brain death. The notion of brain death has many different claims, right, within it. The first biological claim, right, is that when certain vital functions of the brain cease to work, right, they become irreversibly cease to work, then what you have is lack of integration of the entity that is a human being, and that the human being is no longer human, right? So the first part of that, since we don't fully know what the human being is just the biological entity, the functioning of that organism no longer persists. That integrative capacity no longer works. That's the biological claim. On top of that, you have a clinical claim, and there are actually two. One is that our testing of brain death, right, can get at that biological reality. The second is that a prognostic claim that individuals who have been diagnosed as brain dead will not recur or will not have recurrence to any semblance of workingness or function of the brain. Both of those can be problematic, right? But that's the second claim. And the third claim is a metaphysical one. As I said, we don't really know what the human being is. We don't talk about it in medical school. I don't think in the first year of medical school you talk about the human being and how we define that. But there's a metaphysical claim that the human being no longer exists, right? The death of the human being. I'm not specifically not using the term person because there has other connotations there, but the human being no longer exists when the brain has ceased to function. That leads to some social implications. We tell individuals, okay, brain death has occurred, so family members, you can the grieving process can start. Or clinicians, your duty to restore health no longer exists, right? So there's some social implications in the healthcare system that occur after we say that brain death has been diagnosed. This individual is now dead. The human being is no longer present. And there are policy and legal impositions upon that. In some states, in the United States, they have an ability to have a exemption from this diagnosis of death, right, or this way in which we declare death, and some we don't. And depending where you are, there's some implications of what you can and cannot do as an individual, as a caregiver for persons who are diagnosed brain dead. But it's reductionism in action. Why? You've now said, and it's very easy to think about in this sort of way, that if the human being is a rational actor and the rationality sits within the brain, that's what we think, that's what we know, although no one can tell you what consciousness is, then if we can lose that rationality and that consciousness, then that person no longer exists. If that is the sum total of the being, a biological entity, and that part of the biological entity is the most important part because that allows for, whether you think about superconvenience models or emergence phenomena of consciousness, and that is no longer possible, therefore, being isn't there. But if we recognize the mystery of the human being, perhaps you wouldn't make such claims. So with the next issue for me, sorry, the slide moved ahead, is that when we communicate at the bedside, and that we have a fact value fusion. Perhaps those claims are true. They're facts, they're medical facts. That we cannot prognostically get someone back to consciousness, perhaps biologically, although there are people who will argue that there's no way to return some functioning to the brain, right? If those claims are true, they're medical facts or biomedical facts, but we attribute values upon them. And when we communicate to people at the bedside, right, there's confusion. Because what we have done is taken a fact which might have some challenges within it, applied a medical culture value, and then make the family accept that that is what is the truth, the only truth to have. And this, from a Muslim lens, becomes very problematic for Muslim patients. And I'm speaking to an audience in Michigan, for some people of Shiite inclination, particularly, who reject the notion of brain death as a viable notion of death within their legal tradition. So moving to the Muslim lens, this is probably going to be the only slide I really speak to the Muslim lens for a moment, and I can certainly do that in the Q&A. From a global perspective, Muslim scholars, right, have had several issues with the notion of brain death. First being, why is it needed, right? The idea that it was created for, or it serves organ donation, organ procurement was a problem because other ways in which to deal with organ failure were not prioritized. That it is an entity created for this purpose, and is the purpose itself one that is valid within the tradition? Is the value just this? Right? What does it mean? So rightfully so, Muslim scholars and jurists said, well, we're not going to deal with the notion of whether someone is dead or not. We just want to know whether the mechanisms by which we adjudicate or we certify brain death, does that meet the legal threshold of evidence with Islamic law for the declaration of death? So they were very focused, I think rightfully so, on just this question, not the question of the ultimate meaning of what the metaphysical reality of a brain dead person is or is not. And then from that, the implications, right? What are the obligations owed to the individual? What decisions can family take? So then it became all about what is the moral status of seeking healthcare and what is the moral culpability for caretaking of an individual who's been diagnosed with being brain dead. So there were various issues with both the region, the origin of the entity, what does it really mean, and then how we meet out the obligations of the caregivers, both the clinicians and the family in this state. Lastly, in the Muslim world, there is ongoing conversation of whether or not there can be plurality, and should that be part and parcel of how we think about the policies within the states. So, for example, recently Oman came up with a brain death policy, and there were issues within the Islamic tradition where some scholars believe that brain death meets the threshold for legal death in Islam, others do not. And Oman particularly has three different groups of Muslim sects there. There's an Abadi, there's Shi'i, and there's Sunni. And the question became whether the law of the land should have all three views, or at least two of the three views. The last view being that it does rejection of brain death itself, that was left out. But should we have the notion that it's a dying state, and as well as a dead state? And how would we be able to do that in a society where there's a singular healthcare system that the government pays for? The second part. So let's talk about the second malady, commodification and corporatization of healthcare delivery, right? Where bodies become, and the states that the bodies have become ones that can become commercialized. So in this domain, I think the issue is that health is on the market. And you can see that by some of the things, even I'm wearing a Fitbit, right? Some of the things that are on the market that say really that, hey, we can help you have a health solution by giving you data, whether or not that claim is a valid one or not, right? Or we can tell you who you are, right? See the reductionism in action here. Welcome to you. What are you? You're just information encoded upon genes. And that will tell us about your ancestry and about your future health. So it is on the market. And that comes from a philosophy that life is good and you should maximize your life. That it's all about this worldly life. That is all that exists, right? And perhaps we can commodify that notion, and therefore we have solutions outside of the healthcare system to help individuals gain some data that potentially can help them think about how to make decisions about their health. Not all that's bad, but my point here to share with you is that it is a commodity. It is a good on the market. And it comes from a particular notion of what death is about. Perhaps it's an evil, and where we should go. Right? That perhaps death, as I said, men against death, perhaps we should move beyond the limitations of our body and have some ways in which to augment our lives here, right? Or to potentially have close to immortality. Not that that's the reason that these companies are on market, but it comes embedded within a cultural system where this might be a underlying value. So where do we see this? And I want to give you just some sense of that in the, again, going back to organ donation for a moment. The value of organ donation is what? That we can save people's lives, or through transplantation. Individuals will have various organs, not all of them obviously, but various organs that are failing or have failed can have extended lives by having people donate their organs, having a system by which we can procure them, right, safely, and then transplant them quickly and efficiently and safely. But the system, as you recently, JAMA, there's an article in JAMA that came out, there was an op-ed in the Washington Post around how our system of allocation is broken, that leads to certain types of disparities, right? And that we should revise that organ donation system, transplantation mechanisms, and the ethical rubrics that underlie the algorithms by which certain organs are allocated to certain districts. But back to the reductionism at hand here, right? Or the commercialization that bends upon reductionism. So let's think about how organ transplantation systems at academic healthcare systems are rated. They're ranked by the number of successful transplants they have, which leads to certain types of behaviors, right? Because, for example, liver transplantation, the remuneration is $500,000. Kidney, $120,000. So the more you do, the more money you get for the healthcare system, and the higher ranking you have on that system of the transplant centers. And not only that, the better repute you have for referrals for other sorts of diseases. This is known. So if you build a healthcare system that's failing, for example, some places where they don't have an ability to do certain types of primary care, they'll still have transplantation centers because they know that brings in money, brings in repute, and will lead to more referrals. No doubt it saves lives, but it influences the way, those financial incentives influence the way in which you think about it. At the clinical level, well, will we take risks on patients who might die on the bed? If you do that, that will reduce your ranking and then impact the financial bottom line of the institution. All right, will we partner with certain organizations or others? So let me give you an example. Actually, you shouldn't say the state, but in a certain state, there are two different organ procurement organizations, right, that deal with various populations. Some of them, one of them, has some minority patient populations that they primary care to, and the other has majority populations. If you're a transplant system at a hospital, who do you partner with to get organs? Because you know the underlying quality of organs are different for those populations. And there are certain cultural issues in the way that you get the organs and the work that you have to do to build trust. So who do you partner with? And you have some choices to make there. Again, the financial incentives drive the way in which we have a system that is saving lives, but also setting up inequities. And what ends up happening, underlying all that, is a value system of what? That human beings are reduced to transplantable organs. And I'm not saying this is the primary value, but this is embedded within the cultural notion of the system. And if you don't believe me, this is actually true. The next slide here. There are video games. There's a program called Orgamites that you teach children about who they are and how they should think about donating their organs at a young age. It's for elementary school students. That's paid for, right, and sponsored by individuals and organizations involved in the organ donation, procurement, transplantation system. And then what does that make us? So for certain communities, when they say there's distrust, it becomes true distrust. That the healthcare system just wants our organs. They're going to declare us brain dead, which we don't believe is death, early, and because they want our organs to give to others. And that myth becomes a perception that becomes a reality in the way they engage with the healthcare system. So as I already mentioned, those financial incentives inform some bedside dialogue and the prioritization of research efforts and then the healthcare system mobilization. So from my data, I want to share with you a conversation. So part of my research was on organ donation practice in the Muslim community, and I had I had the fortune to record some conversations from organ procurement of professionals as they would engage Muslim families around making the decision to donate the organs of the loved one who's been declared brain dead. And I'm not given time. I'm not going to share the entire conversation, but the conversation went like this, right? That first, your loved one is dead, right? Has been declared dead. There's an ability to make some meaning out of this. They will be able to save up to 7 lives. That conversation happens. The patient's family asks the question: are they truly dead? And the organ procurement professional says, well, there's no flow to the brain, so they're dead, right? They're legally dead, but look, there's no flow to the brain. They put up a slide, they show a slide that talks about no flow to the brain as a brain dead state. The family then says, well, then how come I can see, right, them still breathing and so on and so forth? The organ procurement professional says, this is just an artifact of the fact that we have a highly skilled ways in which we can continue to let the heart have the heartbeat and the lungs have oxygen transfer. Then the person asks, well, what do my religious leaders think about this? So the organ procurement professional puts up another slide. All Islamic scholars agree that organ donation is permitted in Islamic law. And the family is asked, do you want to make a donation? And the family ultimately says no. There were 2 problems there, at least. First, no one tests, and even at the hospital, the blood flow to the brain. That was not a fact. No one was testing. There was no confirmatory test for brain flow to the brain. Whether that's important or not is another question. The other problem was all scholars do not agree. But they had a pamphlet and they had a slide that said all Islamic scholars agree on organ donation. Why is someone communicating like that? Because that organ professional is remunerated on how many organs they have gone to be part of the system. That was part and parcel, not a commission, of how they were ranked amongst their peer group. How many individuals were you able to get to have their loved ones donate their organs? So it influences conversation at the bedside. Again, thinking about what is the value of this person who's nearly dead or is dead? Just their organs, right? That's all that means. And this also plays a role in another example, and I'm going to not go through this fully, but in how we think about reproductive technology. I started the talk asking you, well, does a person who's childless have a disease? Well, the biomedical answer would be certainly. And it would be that we can also help you deal with that disease, right? Through various mechanisms of sperm and egg donation, uterus transplantation, perhaps gestation surrogacy resides adjacent to, but not in the dominant healthcare system, or emerging technologies, like reproductive cloning and synthetic gamete production. That we, as purveyors of these goods, have solutions to what we have constructed as a potential disease. And other arrangements, right, that have existed for a long time, like adoption, or in some societies, polygamy, those are not viable options anymore. We have a biomedical solution in the modern age for your disease of childlessness. The last part, and then I'll stop for conversation. I mentioned the third malady is inhospitability of the healthcare system to certain types of populations. Here again, I'm going to talk a little bit about religion and religious communities. So we know that we want a diverse workforce, right? We know this is an intrinsic good as well as an instrumental good, right? So it's intrinsic good in the sense that it allows individuals, right, to have their notion of flourishing lived out in their profession, right? That we know some populations don't get into medicine. There are certain structural problems with that. So there's a social justice meaning to that as well. And there's sort of instrumental practical motivations that we have a lot of empirical evidence that shows that there's benefits for both patients and for providers if we have a diverse workforce. So increased diversity in the healthcare professions leads to improved access and care for certain populations, improved quality of care, right, and strength of the doctor-patient relationship, as well as improved healthcare outcomes. So this is known for decades, and is why we have in many hospital systems and healthcare systems diversity and equity officers and offices. But let's look at a particular population, again, the one that I come from, the Muslim Americans. And this is a quote from one of the participants in a recent study that I did, a national survey. I'll share some more data in a second. But she said being Muslim or visibly Muslim or practicing Muslim is going to impact us negatively in some sort of way. Now, you might say that this is just for maybe physicians, but the same holds true for patients of this background, right? The patient has to say, I'm a Muslim woman, I have this modesty issue, feeling uncomfortable in that healthcare environment. So let me share some data. I'm just going to share data from the physician lens, and certainly I can bring some data from the patient lens as well. But these are two national surveys I did of Muslim physicians in the United States, right? The only ones that exist. One in 2013, one in 2021, slightly different sampling frames. One was from just a single Islamic Medical Association North America, and it was a survey that was done through paper and pen. The other was online with as well, and it had multiple organizations involved. Nonetheless, let me share some data with you from this research. And I want to particularly note the time trends. So Muslim physicians increasingly experienced religious discrimination in the healthcare workplace. In 2013, about a quarter of the physician group, this is 250 or so physicians across the states, noted that they had experienced in their career religious discrimination. In 2021, that number had doubled, so over 50%. And what type of religious discrimination? And they talked about it in terms of different levels of interaction from patients, colleagues, leadership, and just the institution itself. And what we found was that in higher religiosity, individuals in both groups in 2013 and 2021 who felt that religion was the most important part of their lives had higher odds of discrimination in the healthcare work environment, of increased perception of job scrutiny, struggling to pray at work, likelihood of leaving a job, and patient refusal of care. That their religiosity, not that they're wearing a hijab, not that they have a beard, but they feel religion is important to them, right? And it's the most important part of their lives. All of these negative outcomes occur. And then the impacts of that are both professional and personal. Psychological depression, and I'm not going to share that data, but that existed, 25% of the population. Professional, meaning they leave jobs, and personal tolls of saying, I just want to give up. So Muslim physicians increasingly experience discrimination of patients. I shared this, but here's the number: 9% in 2013, 33% in 2021. Right? And what does that look like? Like this. That this is a quote from a physician that a patient said to them, "How do I know you're not ISIS? How do I know that being Muslim you're really trying to treat me and not to actually harm me?" These are individuals who've gone through how many years of training? This is what they're being asked by their patients. I mentioned that the second level is from peers and supervisors, and I just want to give you a sense, given the time, of what that looks like. I'm not going to read all these quotes, but this is from a coworker about giving someone a hard time wearing a hijab in the OR. From leadership, right? That there's always alcohol on these events. I don't get to participate, and no one takes account. What about their practices? So we're not talking about doing things for other people. Just, okay, I want to have some ability to do what I do as a Muslim, like fast or pray. So here's a quote, right? That I would always ask my supervisor, it's going to be rolling on this time to this time. Can you put in easy rotation? And this is a trainee. Some years it would happen, some years it wouldn't happen. And medical students, again, the onus on the trainees was particularly high, right? That they felt that they couldn't be vocal enough to ask for accommodations of just these idea, I have to go pray, right? Or coworkers would ask, why does this person get two hours to go pray on Friday or for lunch and we don't? Here's another, this is now an attending who was talking about the fact that they worked 7 years straight Christmas, but never had any coverage for their Eid holidays, or even considered by anybody. Again, the notion of diets, right? And then lastly, this idea that people just felt that if I'm more visibly Muslim, there's going to be a problem for me. So what does that mean? What happens, right? So individuals are ostracized or marginalized or just feel under scrutiny in the healthcare system being visibly Muslim. And then what happens? They leave. Right? So in 2013, 70% of our national survey said that they had left the profession due to discrimination in the workplace. In 2021, 32% had left their jobs. Right? And this is a quote from a participant in that study. So my point to you to think about, right, is that I mentioned that I like to see more health equity in the workforce by accommodating physician religious identity. That accommodation for religious dimensions, it proceeds along a gradient. And if you think about, you're at Michigan, many of the people on this call are in Michigan, where there's a huge Muslim population. Let me ask you, at your hospitals or in your environments, or in your training environments, or as well as professional environments, how well do we accommodate just religious observances like hijab or prayer, right? Or do you move to a higher level, beliefs and values, right, around whether abortion is right or not? Can I participate? Can I not? Conscious? Do we have that for trainees or for professionals? Or issues around, I already mentioned, brain death and withdrawal life support of that entity? Or larger scale things, do we have different ways in which we train individuals who have some worldview differences, right? So this is one, for example, where Muslims in a country of Qatar, way back when the medical school was started in 2004, Muslim physicians and trainees were saying, well, we didn't want to learn genital exams on paid actors. That's against our ideology and worldview of how we should do things, whether we accommodate this worldview notion. So it proceeds on a gradient from observances to beliefs and values to larger things like motivations and worldviews and the way in which we want to learn medicine. Do we do that? Do we not? Right? That's the question. So let me end with a couple of things before I open for Q&A. I mentioned I don't want to spend too much time on data about patients, but the same story about the neglect of the religious dimensions of this patient group, the Muslim patient group, exists, right? That we live in an area of known unknowns. Why? Because religious affiliation is not captured in any data sets nationally, and that religious identity is often overlooked in health equity research and assessment. And this is true because of the way we fund it, right? So NIH defines groups that have health disparities and targets specific RFAs for those groups, defined in this way: racial and ethnic minority groups, so that's the identity feature, or people with lower socioeconomic status, that's the identity feature, or rural groups, that's the feature, or sexual and gender minority groups, right? Religion and religious minorities do not make the cut. And if you ask how that plays a role in terms of how we do interventions, here's a national study I did of Muslim patients. And we asked them, were you asked just in normal delivery, you got them into the hospital, right? Did people ask you about your religious affiliation? 3/4 said no. I'm being admitted to the hospital. No one asked me whether I'm a Muslim or not, or I have any background. And I don't know what the experience is for other community groups, but this is a problem in my view. There's a lot of disparities that exist. I'm not going to go through all the data because of this lack of accommodation or attention to the identity of Muslim patients. And in the end, what happens, right? So I will argue that Muslims are seen. There's no way to ignore the fact that someone's coming to your clinic and has a hijab and at least thinking perhaps they're Muslim, right? But they're invisible in the way when it comes to interventions and in terms of data collection and in terms of accommodations for that identity. So for physicians, they go into the profession thinking my religion helps me think about medicine as a professional calling, but it becomes a mark. And for patients, disclosure of the fact that you're a Muslim, no one's asking, but you tell them that you're Muslim, doesn't accrue a package of benefits to them. Oftentimes, it can only lead to stereotyping and discrimination. So the maladies I mentioned were three, right? Reductionism in a wholly nationalistic account of human beings, commodification and corporatization of healthcare delivery, and inhospitability and establishment entrenchment. And this last one, I mean about certain types of minority groups are privileged over others. But going forward, the question for all of us should be, well, what is the future of the profession? Are we going to be, we already do this, right? We do Tommy John surgery for certain professionals because it's important for their lives and their functioning. Okay, so that's not a normal procedure offered to everybody, but to some, perhaps, right? And there are people from our profession who go in and sell things on the other side, right? And do marketing around various formulations and use data to say that these things are helpful. Again, commodification, some sort of expertise. Maybe it's beneficial, maybe it's not. But this is also happening. This is not future. where individuals, right, are being integrated with technological sort of interventions to have them perhaps enhance their visual acuity, right, or enhance their function. Right? So we are in this space now. It's not future, it's bio-present. And how do we as a profession think about that? I think part of the challenge to address those things, or what the profession will be for in the future, is to recognize that our medical education system is indoctrinating us in certain ways. I'm not saying it's good or bad, but it is. And that can lead to some spiritual maladies, right? So here's some. The quest to cure death and find dysfunction, right? The core notions of how we think about disease and define them. And if you consider our first exposures in medical training, be they in the anatomy lab, where we're dissecting a past human being, right? Or in the pathology lab, where we're thinking about slides of what's the organ, what's the function look like, right? Structure equals function. It's reductionistic. We don't start off thinking about, let's look at those people who are octogenarians and how they live their lives. We think about finding disease at the first exposure in medical training. And that disease resides within what we can see. Not in how they live, but what we can see. And that scientific knowing, right? How do we think about biostatistics and we think about studies that are valuable? We look at p-values. And that's not finding truth. It's just saying that we don't think this is a random occurrence of two instances. Even the way in which we think about what is truth in our system, right? How we adjudicate evidence is not, it's about lack of randomness, not about actually true occurrences and causal relationships. That can lead to some arrogance, right? That we have a specialized knowledge, that we trust in our own ability to cure, and an exclusivity, or at least a prioritization of scientific answers to the maladies that are occurring in society. If you think about the fact that when we think about the epidemic of violence, we think about it from biomedical lens. Gun, same thing. Addiction, same thing. Use a biomedical lens by which we think about all problems in society more and more. And there's a complacency for us as physicians with our wealth, privilege, or power, right? We can sometimes see the human being, but more often as an object, right? We can trust in ourselves or we can trust in God. We don't talk about that. And the question becomes for us, right? Are we working for ourselves and our family, or working for society? And I'm going to end with this sort of caricature. So one day, many years ago, I was taking care of a 35-year-old gentleman, African-American, in the ER in the University of Chicago. And I had some sort of feeling that this person could be me, right? I was around that age, but had a similar background, just hadn't gone to medical school. But that individual had kidney failure and had no insurance. I also had no health insurance for many years of my life. Had no health insurance and had neglected to take care of the hypertension they had, presented with kidney failure. I knew at that time that now the person can get Medicaid and get health care, right? But it had led to organ failure to get that. Fine. So what in that encounter, my reflection was the following: that the patient's social determinants of health are being transferred to me as a clinician so that I can live and have health insurance for my kids and my family. I can live in the suburbs and not in the city where there are food deserts. That all of that passage of social determinants from that patient is coming to me through the way in which healthcare is delivered. And so in the story, while I think of myself as the hero, perhaps I'm part of the villain, or the system that's villainous, right? That only allows people to get health insurance at that stage, neglects to find good food or have food deserts in Chicago so people can't access healthy diets, doesn't subsidize those diets, and people don't have any access to know that they have this disease, right, of hypertension, because it doesn't manifest until failure of some organ. So I'll end there and I'll open for questions. I don't have any interventions. There are some here. These are all books that perhaps might help, but I don't have a cure for what I feel are the maladies, and I hope that we can have a conversation about that and work towards that in the future. Thank you.
Thank you so much, Dr. Padela. Amar, are you ready to run the Q&A for us? All right, Amar's going to run the Q&A. Please, we always prioritize questions from learners. If you're a student, resident, fellow, but you can either raise your hand and Amar will call on you, or the chat, and Amar will read the question to Dr. Padela, or feel free to unmute yourself. Thanks, friends. Let's start with questions.
Yeah, so I think there's a couple in the chat going off that I'm just going to start from there. So let's make sure this is a question. Okay. All right. So Barbara is saying, if a Muslim has to go and pray for 2 hours on a Friday, a time that is the middle of the day and there's a lot of work going on, what responsibility do you believe the individual Muslim has for the work that needs to get done during that part of the day? For examples of effective accommodations that you can offer. The same applies for Ramadan. That's an entire month, which can be put off for an entire month. So,
So I mean, the question is whether I think there's a valid question, and that question begs the answer: what's the most important? Right? Are there any other structures by which people can accomplish the tasks of doctoring or caring for patients that don't put the onus on the individual to say, okay, what are you gonna do with the work? I mean, in training, people say, we'll stay later, we'll swap, we'll do whatever else it might be. But does that mean that the entire healthcare system relies on this one individual or this group of individuals so that they cannot take a break to pray? Do we have places in the hospital? I mean, there's many ways to do this. I'm just being provocative, right? People have set up ways to pray at work, meaning they have a room at the hospital. You go for 30 minutes, you come back, so you don't have to reduce the time one has to go, right? Or you have multiple shifts. In some hospitals, people pray at 1, 2, 3, whatever it might be, so that there's not a huge body of individuals going at one time that can potentially disrupt the workflow. And pretty on Friday when people want to get discharged and home. So there are ways to accomplish that. But the question begs is that, are we going to build a system that recognizes people might have some priorities other than just going and filling out charts and signing notes? Or we're not. If we are going to build a system, there are many ways to do so, right? And guess what? 2 billion people, 2 billion Muslims in the world, many of them have hospitals. They've figured it out. People don't stop praying on Fridays because they have to be, they're going to be doctors, and all of a sudden that obligation is waived. So how does that world work?
My name's Barb. I'm the one who put the question in. So I'm actually an outpatient physician. So that I cannot speak to the workflow, except that I have lived in cultures where my religion was the minority and we were expected to accommodate to my majority religion and then to have our services at off work times. Ramadan, however, for outpatient clinics, so because we have our own patients, can become a particular challenge. And because if you have your own patients, the flow of work in is the same. And if you are not moving that work through, whether that's seeing patients or in our current system, that's the inbox, that can be a significant drain on your colleagues. And so you're an ER doctor, and that may not be something you deal with as much, but that has become a significant problem. And I ask this question honestly because we are having problems in our clinic, and I don't have good recommendations for that.
Yeah, so there's a policy report. I didn't put a slide up that we have in specific recommendations for various accommodations. I'm happy to share that with you or with Kristen, and she can share it with you. So let's get down to the practical. You're absolutely right that there's going to be some cost to that, right? We in the ER actually, it's not unheard of. There's certain shifts that my colleagues who are Jewish don't want to work certain shifts, right? And we have upstaffed, upskilled, and we trade and we switch and we allow this because that's what we have to do. 24/7, 365, the ER is open, right? There's no way you can't not have it attending and people are coming in. Right? It's just more acute in that sense, but we've developed mechanisms that there's no penalty. We just figure out ways either socially to switch, or the scheduler knows how to do that, right? So someone will work more Saturdays and I'll work less Fridays. That's how it works out. But there is a burden to bear. Is this a worthy burden? The system, right, here recognizes and that Saturday and Sunday are holidays for certain reasons, right? We made that value system clear. And we made that part of the social practice of medicine, right? And there's no reason that necessarily, as we have more plurality, that those are the days that have to be the days that people stop and do different things. In Abu Dhabi, for example, Friday, Saturday, and Sunday are all considered holidays. They will figure out how to work it, right? Because they have different populations who need those days for different reasons.
Right.
So there are solutions out there. It is going to require some level of accommodation and bearing the burden for some practice groups. There are ways to figure that out. The first question is, do we recognize the being as one might have to do something for or not? But each situation, each contest demands a different type of, right, outpatient versus ER versus, hospitalist versus a surgeon, right, and versus an ophthalmologist. There might be different ways that we think about that. My point in this conversation is just to bring that awareness that it has become inhospitable. And you know what? The other signal in our data set is that Muslim physicians leave the academy to go into private practice. I can control my time. I'm not going to work Fridays. And is that equitable for a population? Is that appropriate?
Yeah,
That we have to
I
maintain our own life? I don't think it is. And so I think we have to have more solutions. I don't want to focus on this particularly. And please don't think I'm just, I'm not giving you some concrete solutions. I'm simply saying that I just wanted to raise the awareness. And there are ways, not just the ones I know, but other systems have figured it out. It will require negotiation, adaptation, and seeing what works in your particular environment. With those who you want to comment.
Thanks,
Well,
Aasim. I would appreciate, yeah, if you could send me maybe that document, I can send it to Dr. Soyster and we can maybe have some ongoing conversation since we are in the same clinic, by the way.
Right. And let me say that I do want to accommodate it. I actually was a hospitalist in a 3-person group with 1 Muslim, 1 Jew, and me. And it actually worked really well for exactly the reasons you said. But I need some more ideas for what we can do in the outpatient because we need some help.
Yeah.
Yeah.
And we have a question from a student, Claire.
Hi, thank you very much, Dr. Padela. That was you covered a lot of different topics that are all very interesting. I guess something I was thinking about during your talk is a concept that comes up quite a lot for among people my age, at least, is sort of the separation of church and state, which is a very kind of a concept that legal scholars do disagree on, right? What that actually means. But I think the kind of mainstream interpretation of it is that there should be no, state-sponsored churches, right? That's the interpretation most people ascribe to, even though people disagree whether that's actually a fair interpretation. I do think people see medicine sort of in a similar way. Science shouldn't accommodate a particular religion, and there are so many out there. And even within the Muslim community, there's sects and there's differences of opinion and interpretation, which you've already raised, talking about different ideas of brain death. How would you even, within kind of a scientific discussion where you're trying to establish evidence-based criteria, how would you even begin to choose how to include representatives of which groups to be involved in that discussion? I just think it's like a huge cultural hurdle, at least here in the United States, to do that. And I think the answer you've posited a little bit is that, look, we value diversity and this is an important form of diversity we're ignoring. But I think religion does also have this particular status, separation of church and state. And I think in people's heads, separation of science and church. How would you make, is there more to your argument than just, this is another form of diversity?
So there's a very, very good question. There's various ways I can address this question, but let me give you one idea. So the idea of separation of state is fine, but the idea is non-establishment and free exercise, right? That's the amendment, right? So the idea that we don't establish, but we don't limit exercise. So there's the opposite side of the coin, and legal scholars have various views on that, how that is meted out, and sometimes that is politicized by which parties in power. But the reality is, it's not just one or the other. It's non-establishment, but also less restrictions. There shouldn't be constraints on exercise of religion, unless there is a state interest at stake. So that's one thing I want to talk about. The second concept is the notion of consequences of belief and burdens of belief. Burdens of belief are borne by the individual. Societal discussions are about the consequences of belief because it involves societal implications of what we're going to do, like we're talking about right now. Is my group going to bear this sort of consequence or not? Meaning physicians will no longer, Muslim physicians, I'm not saying this happens, but it does happen. There's some signal. We'll leave the academy, we'll go work on our clinics, and that's it. That's the consequence. Is society willing to bear that consequence of healthcare workforce inequities, right? Or the consequence in our work group, right? The consequence is that we will not be able to have certain types of patient care that is culturally appropriate. And that's where discussions occur to see whether or not there's an overriding interest of the state or not. So there's many court cases that deal with this notion, right? Around burdens of belief and consequences. Burdens of belief, hey, I have a burden that I believe that life doesn't end in this world, there's another, and I'm going to bear that burden. Or I believe that XYZ, that life begins at conception. Okay, that's your belief, right? That's a burden of you bear that burden. Is it going to be meted out in society that's what we're going to make law? That's a conversation. in society that has to happen. And a society presently that's polarized and doesn't have civil discourse is a problem. But that's part of why we have policies. That's why we have discussions. That's why we have public reason. We make those conversations happen because they're important in a diversifying society. So is there more to me than just saying, hey, let me take the diversity lens and tell you that you're ignoring diversity? I'm telling you that there are costs and consequences that we neglect, right? And I'm telling you that's problematic for me. That's a malady of medicine. I'm not sure where the future of medicine would go like that, because the values that are stated in the way that we deliver healthcare now, diversity, inclusion, equity, they're all at risk. Are we going to do something about them? If those were not the stated values, then we can talk about something else. But there are other things, right? We have poorer outcomes for patients and clinicians. We have ways in which I mentioned, we're defining diseases for certain types of things that perhaps that's not the way we should think about diseases. There's social ways to address those issues, but we neglect all of that. So I'm concerning the future in a plural society, right? Of I'm actually raising the question of what we're going to do. I don't have solutions. I'm just saying that's becoming more and more problematic, again, with some empirical data at this community level, right, for Muslim physicians and Muslim patients.
Well, friends, we unfortunately have come to the end of our time together. Dr. Padela, thank you so much. And for anyone of us to continue the conversation, come join us at the Conference of Medicine and Religion in April in Indianapolis. I just want to just give a shout out to our amazing chaplains and members of the spiritual care department who've put some incredible resources to the chat. If you're at Michigan Medicine and you're a Muslim and you want to be on their listserv, it looks like they have a dedicated listserv for events. And Dr. Wright, who leads spiritual care, has offered to even help think about staffing challenges and different aspects of the hospital to try to accommodate. So thank you so much to all of you for participating, for all of you for coming. Hope to see you all in person again soon. God bless you all. Goodbye. Thanks, Aasim. By the way, it was a great talk. Thank you.